is one of the question. A 32-year-old female presented with heavy hair loss since 4 months. So some students, they were telling that this history of 4 months is given, so I have made it 4 months. Some other educators have made this have not made this small correction. They have told that there was some hair fall since few weeks. Okay, so it was mentioned as 4 months, and she gives history of suffering with COVID-19 8 months back. 8 months back. Okay, so what does it mean? 8 months back she had COVID-19, which is a viral infection which can be associated with a acute fever. After that, we can say after 4 months she has developed a hair loss. That is, since 4 months she is having this diffuse type of hair loss. This image might not be the same exact question, but having seen this question and the duration which is mentioned, that is, the scenario is after fever the patient is developing a hair loss. So if you look at the options, you can easily rule out few options, and I have seen many students have told me the same thing, that out of the 4 options they were able to eliminate 2 options very easily, but among the 2 other options which were left, they had difficulty in choosing the correct answer. So in the options you can see trichotillomania is there, and yes, trichotillomania is seen more common in female population, but there will be a history of pulling out of the hair by the patient, or there can be a history of hysterical female which will be mentioned in the question, but not COVID-19. So we can rule this out. And also in alopecia areata, there will be a patchy loss of hair which will be depicted in the question, but many students told that it was a diffuse type of hair loss, whereby the hair loss was more of in the crown area. So we can rule out alopecia areata. And coming to androgenetic alopecia, please remember androgenetic alopecia, it is more common in males, and it is not very commonly seen in the females. And if it has to be androgenetic alopecia, there will be a mention in the question that the patient has a preserved frontal hairline and the rest of the hair is falling off. There is loss of hair except for the frontal hairline, but nothing as such is mentioned in the description, so we can rule this out. So we are left out with one option, telogen effluvium. So that is the answer here, it is telogen effluvium. So let us see what is this telogen effluvium. So basically effluvium, wherever you see this, you just remember it means shedding. So if telogen phase of the hair is shed, it is called as telogen effluvium. And you must also know that the hair cycle is made up of anagen, catagen and telogen. So these 3 go in this same format, anagen, catagen and telogen. So what happens is, in certain conditions whereby the patient is affected with some form of acute or chronic illnesses, then the anagen phase of the hair, which actually has to stay for a period of 3 years, instead of this 3 years duration, it will convert into telogen. And you all know, I hope you all know, that the telogen will only stay for a period of 3 months. So there will be a shedding off of the hair. So 85% of the hair in any given individual is in anagen phase, but suddenly this 85% of the hair is getting converted into telogen. So there will be a sudden loss of the hair, and there will be a diffuse type of hair loss present over the scalp. And there are many conditions which can trigger this telogen effluvium, like pregnancy, it can be major surgery, it can be cardiac arrest, it can be major illness, it can be any form of hospitalization, chikungunya, dengue, typhoid, and yes, COVID-19 also. And in fact, there were many studies after COVID-19 infection whereby patients presented with telogen effluvium. So I will show that in the next slides. So here you can see this is a study, telogen effluvium as sequel of COVID-19, and in this very carefully if you observe, I will highlight it also. So you can notice that patients who were positive with COVID-19, time after COVID-19 to presentation at dermatology clinic, and what was the symptom for the presentation at the dermatology clinic, it is telogen effluvium. And you can see that the duration can range from 3 months to as long as 7 months. Even 7 months after they becoming positive for COVID, they can present. The patients have presented in fact with telogen effluvium. Okay, so I hope some students had this confusion that no, telogen effluvium only after 3 months it should be there. So how come it is after 8 months? So in the question, actually, if you observe carefully, it is shown that 8 months back COVID-19 was positive in this female, and since 4 months she is having this hair loss. So approximately you can say after 4 months of COVID-19 development, she is having this hair loss, which is telogen effluvium in this case. And if you want to watch the video of hair cycle which is described and explained by me, you can check out. I will leave the link in the description. About ACT, there is also a beautiful mnemonic for that. And this is the next question. A farmer having a history of trauma in the lower limb, following which a cauliflower-like growth developed on that site wherever that trauma happened. On histopathological examination, copper penny bodies are seen. Now, I am not sure whether this copper penny bodies is mentioned in the question description or whether it was only given in the form of a histopathological image. So, please type down in the comment section what was actually given in the question. So, what is the diagnosis? So, with these clues which are given, that a farmer, the occupation is also important, and there is a history of trauma which is also important history. Why? Because this is a question in which the differentials can be deep fungal infections, and because of the trauma, these fungus, they are going to get inoculated deep into the tissues, and thereby they are going to produce the manifestations. So among the given options, you can see chromoblastomycosis, mystoma, sporotrichosis. All of these are deep fungal infections, whereas cauliflower-like growth, and this cauliflower-like growth can be seen in the case of chromoblastomycosis. Yes, Redowitberg says image was different, it was more in the center. Yes, even if it is in the center, then according to the question body which was given, it is most likely telogen effluvium. It is telogen effluvium, okay. And yes, here it is chromoblastomycosis, and mind you, this is a very important question. Why? Because the same exact question, almost same exact question, was asked in the INICET May 2022, which I have even discussed. Picture of medullary bodies was mentioned, and the options were, these medullary bodies are also called as what? So there are various names for these medullary bodies which are also called as copper penny bodies, which is sclerotic bodies or muriform bodies, and these are all seen in the case of chromoblastomycosis, which is caused by Fonsacea pedrosi most commonly. And you can see the verrucous dermatitis is the other name for this chromoblastomycosis. The reason being that the growth which can be seen over the skin is going to be very much like warty lesion. You might confuse that it is caused by human papilloma virus because of looking at the warty lesion, but no, it is in fact deep fungal infection. And these are various other questions. If you know the answer for these questions, just type at the question number 274 and write down whatever answer is correct for these questions. These are additional MCQs which I am leaving for your future reference. And this is the next question. A patient came with some nail changes. On examination, you identified that there is irregular pitting and subungual hyperkeratosis, and oil drop sign was positive. So what is the diagnosis? And if you have marked psoriasis as the answer, you are absolutely correct. So now let us look at the nail changes which can be seen in the case of psoriasis, but before that, let us look at the nail structure. So just briefly, the part of the nail which you can touch and feel, it is called as a nail plate, and this nail plate rests upon nail bed. And you must know that the nail matrix which lies at the proximal part of the nail is going to produce a nail plate. This is one thing which you must know. So now coming back to the question. So in the case of psoriasis, you all know that there is parakeratosis which can be seen in the skin lesions. If you remember in histopath, you might have read parakeratosis, and the same pathology happens even in the nail. That is, in the proximal nail matrix, this is going to happen, that is parakeratosis, and because of which clinically the nails are going to show pitting, And what is the basic funda behind this is the parakeratosis is nothing but the presence of the nuclei in the stratum corneum. Okay, if you remember. And because what is the reason for that? The reason for that is because of the rapid, very very rapid proliferation of the stratum basal cells, and they are moving towards the stratum corneum. That was the reason for the presence of parakeratosis. And similar situation happens in the nail also, because of which the nail surface, which should be even, at certain points, because of the presence of parakeratosis, there will be very very rapid proliferation, and the nail which is reaching onto the surface is going to be shed off, just like the scales over the skin. It will shed off from the surface of the nail, because of which there will be presence of pits over the nail, and it is the reason behind this pitting of the nails. And you must remember that pitting of the nails is the most common manifestation of the nail psoriasis. And you must also remember that psoriasis, and there is one more condition in which there will be pitting, which is very important for the exam purpose. Both of these are exactly contrasting features of pitting will be seen. One is psoriasis, in which there will be irregular and deep pits which can be seen in the nails, whereas in alopecia areata the pits are going to be very very regular and they are going to be very superficial. I will show you this in the form of image. So a small quote from Abdul Kalam ji: small aim is a crime, have great aim. You should aim for the stars so that at least you will reach the moon. So why am I telling you this quote is because, like the moon has the irregular pits, just like that, in the case of psoriasis, the nails are going to have this very irregular and deep pits. So just for the comparison I have told you. So in the case of this is a picture of a patient having psoriasis affecting the nails. So yes, this is the most common nail finding, and just contrast that with alopecia areata. In which the nail pitting is going to be very regular, as if someone has taken a scale and they have drawn the pits. So that much regular the pits will be, and also they are very superficial pits in the case of alopecia areata. In fact, this nail pitting is called as geometric nail pitting. And nail changes in psoriasis can be seen in the case of 10 to 50% of all the patients, and there can be two possible structures which can get affected. One is nail matrix and the other one is nail bed. So because of the nail matrix in psoriasis, the nail pitting and leukonychia, these two changes can be seen. And here you can very clearly see that oil drop sign is being depicted here. What is this oil drop sign? Basically it is the yellowish tinge which can be seen below the nail plate. This is the yellowish tinge, and because this is looking like a oil drop has been kept in between the nail plate and the nail bed, it is called as oil drop sign. This is also called as salmon patch. And this is a pathognomonic sign which can be seen in psoriasis. And there is one more condition called as oil drop cataract. So if in the exam you have read this in a hurry, you might have by mistaken marked galactosemia. So that's why you should be very careful. Why? Because galactosemia was also there in the options. Galactosemia will have oil drop cataract. So these are the nail bed and its manifestations, effect of psoriasis on the nail bed. As you can see here, oil drop sign, salmon patch, pathognomonic yellowish discoloration. And what are the other changes? Subungual hyperkeratosis and onycholysis can be seen, and there will also be thickening of the nail plate which can be seen. And what is onycholysis? If the nail plate gets separated from the nail bed, it is called as onycholysis. And just with the analogy of this picture, you can remember this. So if you consider the road as nail bed and the subungual hyperkeratosis as the jockey, and yes, this car is in fact the nail plate. And if you just see the subungual hyperkeratosis, it is going to lift the nail plate from the nail bed, which is going to produce this onycholysis. So I hope this analogy is very helpful for you to remember the manifestations of the subungual hyperkeratosis producing onycholysis in the case of nail psoriasis. So please give a thumbs up if this explanation was helpful in your understanding of onycholysis and how it is produced. So here you can see the subungual hyperkeratosis. It is present as whitish material in between the nail plate and the nail bed, and this is the one which is going to lift and cause the onycholysis. Okay. So do give a like to this video if this explanation was helpful, friends. And yeah, now let us move on to the next question. This is the next question, and yes, this was the picture which was showing this BITOT spots, and it is observed in, yes, it is seen in vitamin A deficiency. So nothing much from my side. It is actually we can say ophthalmological question. So just try to answer this MCQ question numbers 185, which was asked in my Telegram group. What are the causative deficiencies which can produce PHRYNODERMA, which is also called as toad skin? So leave your answer in the comment section if you know the answer. All of them can produce except for one vitamin. Okay, you can join my Telegram group. The links are there in the description. Okay. This is the next question. There is a 0.3 centimeter ulcerated nodule over the tip of the nose. So this was the site which many students told. They told that it was not mentioned as medial canthus or inner canthus. It was mentioned as a tip of the nose. On histopath, you are able to see this image was given in the question. So what is the diagnosis? So the image actually clearly depicts these cells from the epidermis. They have detached themselves and they are present in the dermis, and they are having this palisading pattern. This we can say is an integrated question of dermatology and pathology. So palisading pattern is present, and you observe that tip of the nose is having ulcerated nodular lesion. So the clinical features of ulcerated nodule can be present in basal cell carcinoma, and also the site is also favorable site for basal cell carcinoma. Why? Because if you draw an imaginary line from angle of the mouth to the tragus, and the site above this is more routinely involved in basal cell carcinoma. So here basal cell carcinoma is the correct answer. In fact, basal cell carcinoma is the most common variety of the skin malignancy, and in this there is one pathway which is activated. So I want all of you to answer what is the pathway which is activated. This is my MCQ from my side. So clinically there will be pearly translucent nodule which will be present with surface showing telangiectasias, that is dilated arteries and veins will be present. So permanently dilated arteries and vessels present over pearly translucent nodule is the classical clinical description in the case of basal cell carcinoma. And when this is going to become ulcerated, then there is going to be a central erosion which can easily bleed on touch, and mind you, this nodule, because of the excessive necessity for the blood and because of the reduced blood supply, ultimately as the nodule grows and grows, the blood supply will be insufficient to cater to the needs of this nodule. Then there will be development of necrosis, whereby there will be formation of ulcers, and these ulcers are called as rodent ulcers. So yes, in the patients can present with ulcerated nodule in basal cell carcinoma, and yes, you can see this was mentioned in the picture, palisading arrangement of these basal cells. the epidermis basal cells. And this is a clinical question which I have asked in my Telegram group. You can answer that in the comment section after the session is finished. What could be the possible association with the skin condition which is shown below? And many students told that the front of the neck was having some dirty dermatitis like features, and there was hyperpigmentation. So we can see that there is some velvety texture present. Velvety texture is seen. And where is it seen? The velvety texture is seen over the skin folds. Skin folds. There is hyperpigmentation also which can be noted, and most likely this is a picture of acanthosis nigricans. Acanthosis nigricans, acanthosis nigricans, and you must know that there are two types of acanthosis nigricans. The first variety is benign acanthosis nigricans, benign variety of acanthosis nigricans, and the other one is malignant variety. In the benign variety, just remember the age group which gets affected is young age group. And what are the possible associations in benign type of acanthosis nigricans? It is obesity, which is the most common association, followed by diabetes mellitus. Whereas in the case of malignant type of acanthosis nigricans, the most common malignancy which you must remember is gastric adenocarcinoma. Gastric adenocarcinoma. And in the case of obesity, I hope all of you do remember that obesity can be associated with metabolic syndrome. And not only that, even acanthosis nigricans can be associated with one syndrome called as Hyran syndrome, whereby AN stands for acanthosis nigricans, IR stands for insulin resistance, which can lead to diabetes mellitus, and HA stands for hyperandrogenism. Okay, so in this way we can mark metabolic syndrome in this question, treating this as a case of acanthosis nigricans. Okay. And not just that, there can be other possible questions which can be asked from this topic. So please leave your answer. This is a NEETPG 2019 MCQ. So if you know the answer for this question, please leave the answer for that in the comment section below. And this is the next level question. So you must be very careful while answering these kind of questions. So please leave the answer for this question as well in the comment section below. So this we have already seen. The most common association is obesity, and yes, malignancy associated acanthosis nigricans, the most common is gastric adenocarcinoma. So genital warts are there in a patient. Genotyping was done and it was observed to be a high risk cancer. What could be the possible human papilloma viral strains? So students, some of the students, they have not seen this point, that the question mentioned that high risk cancer strains were noted, and because they have not seen this, many students they answered it as 6 and 11. But remember, yes, 6 and 11 they are associated with genital warts, but the thing is that the 6 and 11 are associated with benign variety of genital warts, whereas 16 and 18, and not only that, 31, 32, 51, these are all associated with highly malignant variants of the HPV strains. So you must remember these strains: 16, 18, 31, 33, 35, 39. Up to this you can remember, it will be sufficient. And in fact, this was the INS-CET MCQ, and you can see what was the INS-CET question, which is not associated with high risk HPV infection. So the answer there was laryngeal papillomatosis. It is associated with HPV subtype 6, which is associated with benign variety. So high risk and low risk, the context here is about malignancy. So if the strains are associated with malignancy, they are given a high risk description, whereas if they are associated with benign types of HPV strains, it is described as low risk. So now coming to the Hansen's question, a patient undergoing treatment of patch of borderline tuberculoid leprosy on the forehead, nose and bilateral cheeks. What is the most common nerve affected in this patient? So and also I will leave the literature for the involvement of facial nerve and what will be the manifestations because of the facial nerve involvement. Okay, so I hope this session was helpful. Please do not leave this video without giving a like